It's also a very difficult period for me because that's when I had my first suicidal patient who ended his life. Like in Northwest London, there's a very big drug problem. You've got spice, you've got cut, you've got, many different types of drugs.
The phrase, how are you? I think that needs to be expanded upon, and actually someone sit down and say, look, how are you? Is everything okay? It's not just you're passing someone in the hallway and you say, you're all right.
Even the speech, the way people speak, they say, oh, I'm depressed.
The word is very, it's abused.
It's abuse.
Yeah. And then I was asked to go and see this patient and I was terrified. Honestly, I was literally terrified. I was like, it took 12 policemen, special forces to bring a patient. Now you're asking me to go and see this patient at like 2 a.m.
Yeah.
So sometimes they can tell you something, they make fun of how you look or your name or your, be like, oh, I'm Muslim. So they can be like, oh, you're a terrorist or some things like that. So
basically found out some devastating news, with regards to my personal life, regards to family. I was close to shedding tears at lunchtime because of what was going on. But then I just had to wipe it away and just go. And I was dealing with a family discussion for a patient that's end of life.
Being a man, do you actually talk about your feelings that much? How will people perceive you if you're in the middle of 5 other guys and you cry all of a sudden and you say,
Hello and welcome to a brand new episode of the Strive Med podcast. If you're watching this episode, make sure to press the subscribe button right now. This is the latest hour we have ever recorded a podcast right now, putting in those crazy shifts, bringing the best possible content for you. Make sure to subscribe. Follow us on Instagram, Strive Med, TikTok, Strive Med, putting out some crazy videos out there, amazing content. And www.strivemed.co.uk for all of your help, GCSE, A-level tutoring, medical school applications, work experience, and much more. Today we have a brilliant guest. Just to introduce everyone, myself, Dr. Anam.
Dr. Zach.
And so today we have a very, very special guest with us, Dr. Mostafa Shalaby, and consultant psychiatrist. And to be honest, I just wanted to say thank you so much for coming down.
No, thank you very much for inviting me. It's a pleasure to be here.
Honestly, and to be honest, psychiatry is something which I feel is extremely important. And it's very, very important we have this podcast, not just for the medical community, but also for everyone. Yeah. Everyone, just for the human race as a whole, to be honest, because we have all been impacted by psychiatry in some way, shape or form in the years that you have been living. Whether you have experienced the illnesses of this nature, of the psychiatric nature, or if you have known someone who has been impacted by it. Yep. I'm pretty sure every single person on the planet has encountered this in some way, shape or form and has their own story with it. I remember my understanding of psychiatry and all of these forms of illnesses was different when I was growing up, as a teenager. And I saw different things in medical school, different experiences from the people around me, the people in the hospitals. And obviously now it's much more refined, much more developed. And I think as well, we need to, as a society, know how to care for these people. It's not just the psychiatrists, the consultants over there. It's not just the people in the hospitals. It's everyone. We all need to look out for each other. And that's why I think mental health as well, it's very, very important. Just like there's a big impact and a big societal consideration for physical health,
definitely,
we need to consider mental health as well. And if you look at the hospital perspectives, it's actually profound because us as F2s, right? We've done so many different specialties, all of these different specialties, but our psychiatry knowledge has been tested in each specialty.
Of course.
Because at the end of the day, we're dealing with human beings. Everyone's going through hardship. Everyone is in hospital and everyone needs that psychiatric support from time to time. And you have patients and we have this crossover from psychiatry where we actually need to understand what is occurring. Do we need to seek further help? Is there some sort of aid we can give them, be that medicinal or be that another form of psychiatry support? So it's actually very profound. Thank you so much for coming. Just wanted to touch upon your thoughts with regarding that intro and the importance of psychiatry. And to be honest, I just want to start off by asking your journey with psychiatry, because as I said, it changed for me as I went through the years and my experience. So what was that journey with you for psychiatry such that it brought you to a position where you want to dedicate a major portion of your life towards helping patients of this kind?
Yeah, so just to comment on what you said in the beginning, I agree definitely with what you said. And one of the sad things is that I think until today, psychiatry is neglected. Maybe COVID opened our eyes a little bit to the importance of mental health around us and obviously the impact of the lockdown and all of this, which we'll talk about later. But at the same time, it is still neglected, and we still need to know much more about psychiatry. There needs to be more funding, there needs to be more support. People need to know much more. And again, it's not only about psychiatric illnesses, it's all of us, it's mental health is a massive spectrum. And I think all of us have mental health issues one way or another. It's not that you have to be within this box to actually seek for help. All of us need support. And until today, people find it very difficult to say, oh, I'm seeing a therapist or I'm on an antidepressant, etc. And you find in the news people, they're writing about antidepressants being addictive when they mean benzodiazepines, things like that. And it's really, really sad to hear that, because a lot of the people get impacted by that. But to go through my journey, so I did medical school in Egypt, and then I come from a family of doctors, and the first thing was that, you need to be a surgeon in the UK. And I did my F1. It was kind of surgery themed. So I did TNO and general surgery and acute medicine.
Similar to us.
Yeah.
Oh, really? Okay, yeah. I honestly didn't enjoy it very much, especially the surgical part. And, the reward is for the consultant to get you to go to theater for like a day or something. And even when I did go to theater, I didn't feel that, oh, I'm enjoying this, or this is really what I wanted to do. Plus, I didn't really feel good at it. Like, I didn't feel that I was actually going to be a good surgeon. Fast forward another year, I got offered to do an F2 job, which was a training job. And then I said, okay, I'll finish F2 and then think about what I want to do. At this time, I was actually thinking of leaving medicine completely.
Okay.
Just didn't enjoy it very much. And then I had a TNO F2 job. This was my first job, which was quite challenging. And then luckily afterwards, I did psychiatry. And the reason why I did psychiatry was because this was the only theme where I would do obs and gynae also, because I was thinking of doing obs and gynae then. And I did psychiatry, and I just loved everything about it.
Amazing.
Because you, especially growing up in Egypt and doing medical school in Egypt, people think that, as a psychiatrist, you don't really do much, you don't change people's lives, but you literally get a patient or someone who's really, really unwell, not able to have a family, not able to function on a day-to-day job, not able to sleep, not able to eat, physically neglected, and then you're able to get them back to life. Within a few months, they're able to go back to work, stay in a relationship, able to do normal day-to-day things that we all take for granted. So, and you see people at their lowest points, obviously, and the highest points also if they're bipolar or something. But it's an incredible specialty. And then I applied for psychiatry training within London. Luckily, I got it, and then did the SHO training and then SPR training, and this is my first consultant job now.
Fantastic. That's remarkable. We always talk about on the podcast, everybody has their own unique journeys, and it just shows you how diverse medicine is within itself. When you're applying to study to medicine, there's a lot of people put themselves in a box, and they think about either doing surgery or doing general medicine specialties like cardiology, gastro, or
and my parents were really, really against me doing psychiatry. Actually, in the beginning, they were like, "Oh, they told me you're borderline crazy. So if you do psychiatry, we'll need to we'll worry about you." But in reality, now they say this is the best decision you've ever made. That's because obviously the stigma has reduced a bit in the last few years, and even the stigma between doctors has reduced now. And they felt and they saw actually you're doing a massive impact. You're helping people so much. So it's an absolutely great specialty to be in.
That's amazing. I think the thing is also we need a lot of people need to consider psychiatry as a specialty. For some people it works obviously, and for some people it doesn't. But there's you mentioned, obviously you alluded to the word stigma, and there is something associated with the fact that there's the illnesses of the body are a lot more sort of prioritized, whereas the illnesses of the mind and, you know, mental health is not on the, you know, not on everyone's mind until they're afflicted or they know someone who is afflicted. So it's important that we educate ourselves. It's important that we raise awareness, and it's important that we sort of, you know, we promote and we encourage others to go into the field if they're interested in it, because ultimately it helps us as a society progress and move forward. You know, you touched on that's an amazing sort of journey that you've had, and I wanted to pick on something that you mentioned earlier, and you mentioned how in COVID we saw the pandemic, we saw, you know, a lot of these sort of psychiatric illnesses and mental health, they were perpetuated by lockdown, etc. First of all, I wanted to start off by discussing your experience in COVID. You must have been working at the time. You were working within psychiatry. How did you find, what was your experience sort of working within this field at that time?
Very difficult experience. I remember, I mean, it's a bit of like an issue for me, because I remember when I used to go to A&E, you know, you would see on the news that, especially with lockdown, you would see on the news that, you know, oh, most of the patients, you need to stay at home and we have to put a lockdown in place and no one's allowed to leave their homes. And then especially during Christmas, I think that was when, because they said first everything's going to open up, and then they said, no, actually you need to stay at home.
Yeah.
And I think that was the most, probably the busiest period of my life within working in psychiatry. And it's also a very difficult period for me, because that's when I had my first suicidal patient who ended his life. And I saw the impact, especially I would say December 2020 and January 21, because people expected to, you know, have a breather. They're able to see their families, they're able to do things, and then all of a sudden, no, you have to stay at home. And this increased the stress so much for people. And the reality is, stress is the beginning of all the mental health issues. You know? And then this, you know, people who had just anxiety, that they were able to control it with CBT or things that they've learned in CBT or medication, their anxiety became much, much worse. And then, you know, this ended up for some people having suicidal thoughts. So when I would go to A&E, you would find that actually about 25% of the patients are mentally unwell patients. You know, it was a very difficult period.
That's actually profound, and I think that impacts someone in every walk of life, because I think one of the things which was taken away was the idea of outlets, because these tasks of daily living do actually impact you for mental health in a positive way.
Sure.
Like I was and to be honest, it applies to so many people in society. You may not actually realize it until you dig deeper. Like I remember I was with one of the individuals, very, very strong jiu-jitsu fighter, right? Like a very well-renowned jiu-jitsu fighter. And he was mentioning to me that when the lockdown occurred, he couldn't perform his jiu-jitsu, he couldn't train. And he actually had attempted suicide during that time. He reached the stage where he attempted suicide. And this is actually something profound. Like myself and Zakaria, we've lost a lot of loved ones to suicide. And like, this is not the way that, you know, we feel like we need to discuss this more on open platforms like this. And just talk about it. And I think we understand that you're very passionate about men's mental health as well. This is something that impacts men as well. So just to touch upon a few different statistics which we have, 3 times as many men as women die by suicide.
Yeah, can I comment on this? Because this is like one of the most important things. And it's a very interesting statistic, because this is completed suicide. But if you actually look at the statistics for attempted suicides, it's higher in women.
It's even more. Okay.
No, it's higher in women than men.
Okay.
But then when you look at completed suicide, you find that it's much higher in men, 3-to-1 to 4-to-1.
Okay.
Do you know what the reason for that is?
So men actually go through with the suicide attempt.
Yeah, completed. Yeah.
But women attempt it more.
Exactly.
Okay.
Why do you think that is?
No idea.
Because women are much better at seeking help than us.
I see. That's crazy.
So the problem is men would go through stress, depression, whatever they're going through. And the likelihood of a man actually seeking help is much lower than a woman. Even if you think about your friends, you know, being a man, do you actually talk about your feelings that much? You know, how will people perceive you if you know, you're in the middle of 5 other guys and you cry all of a sudden and you say, you know, oh, like my girlfriend dumped me or something.
Yeah.
You know, you'll be worried to do that. But if you go, you know, and you watch 6 women going out together, if that happens, that's completely normal. And they're all, you know.
Some people say that when women meet up, there's a lot of therapy. They discuss things a lot more. So
which is great.
Therapy happens, which is important. That's the thing. As men, we tend to bottle things up. You know, we keep it internal, we keep it hidden. Which is to be honest, that's very profound. We never knew that statistic, to be honest with you.
And I find it like the first time I read about it, I was like, this makes a lot of sense.
Yeah.
And that's why I promote women's mental health also, and especially postnatal depression, things like that, because a lot of people are unaware of that. But the thing is that men need to be much more open about their life, about their feelings, about their emotions. We need to, you know, like both of you, I don't know if you're married or not, but, you know, if you do have children, you need to tell them, actually, it's okay to talk about your feelings. You don't need to be like, oh, no, actually, you're a guy, you shouldn't cry. And I don't know about you, but I was raised that way. You know, you're not supposed to talk about your feelings at all. And then that leads you to, the older you get, the more you bottle up things. And then instead of like crying for help, which is like an attempt of suicide, you go through it straight away.
Does your approach change then in a consultation? Let's say, does you as a psychiatrist now, when a male comes to you, or for example, compared to when a female comes to you, and and you see that obviously this might be a male who hasn't opened up before, he's coming out to seek help. Would your approach change, or
yeah, I mean,
do you do certain things differently in terms of your consultation? Or
I wouldn't do things differently, but the risk assessment is a massive part of our job. Basically, we you know, we get paid to do that at the end of the day, because we make decisions to see if a patient needs to go into hospital or not, against their will, or if they agree to it or not. And it's like so the highest number of suicide would be in a middle-aged man.
okay,
So if I get a single, like either a single male or someone who's recently broke up or divorced, etc., lost his job, something that's going on, you know, very difficult for him, and he has suicidal thoughts, I would really, really worry about that.
So there's risk factors you would look for beforehand when sort of this male comes to your consultation, that will make you sort of think that, you know, I might have to sort of think about other sort of management plans or change my approach when it comes to this individual in order to, you know, give them the help that they need.
I would worry more. Yes,
Okay.
I would definitely worry more if I get a middle-aged man with certain criteria that I know about. That would make me worry a bit more.
So just to transfer this knowledge onto the general society, so ways we can help them. So first of all, I would just wanted to discuss risk factors in totality, warning signs, okay, things we should be concerned about. If someone doesn't quite open up, but you can see that, okay, he's showing signs of concern, that we should maybe look into this more, things like that. And then furthermore, if there is actually someone with suicidal ideation and you find out about this, what can actually be done, and what's the best way to deal with it?
As a person in the general population, I think the most important thing is to be there for that person. So one of the things that people think about a lot or say is that, you know, if someone's feeling depressed or something, or they feel that they're changing, they kind of force them to talk. Okay, so be like, oh, tell me what's wrong, and they keep, and that's not the right approach. Okay, you need to ask them. I would tell them, I'm here for you. Okay, I support you. If you need any help, then please let me know. Or if you want to talk about something, please let me know. But just constantly nagging them to tell them, oh, you know, you have to tell me what's going on, that would just add up to the stress that they already have. And then the other thing would be to navigate them to the right help and to normalize things. So to say, you know, oh, I know a few people who have been through something similar to that, you know, medication really helped, or going to a therapist really helped. You know, maybe they need to visit their GP. But if anyone has suicidal thoughts and it's reached that degree, and, you know, in something like the ICD-11, we worry about someone from, you know, having, we would say, from mild to severe depression straight away. If someone has suicidal thoughts, this is like a very big thing. So if something like that happens and I'm actually concerned about that person, then I would call 111 or take them to A&E, see how serious it is, and then act on it straight away.
Okay, amazing.
Understood. That's actually profound what you said, and I'm very interested to know that you mentioned that you grew up in a certain way, right?
Yeah.
Which was not very supportive for sharing your feelings, for example, the males. And I even noticed this myself, Zakaria, like whenever we come on the podcast and we discuss our experiences in the workplace as well, that's a big stressor. Like we can't lie, as medical professionals, oftentimes discussing our experiences and knowing that everyone else is in the same boat as us and we're going through things together, it feels like that's a breath of fresh air for me, and I feel more rejuvenated and things. It is in a sense, even doing this podcast, it is therapeutic in some definite sense. Like natural conversations like this and the art of conversing, nowadays society, it is actually quite lost. And even just checking up on people, everyone seems to be very focused on themselves, especially with the social media. I notice this like lack of communication as well. Like if people are around each other within society, they'll just be on their phones. And even people who know each other, they'll be on their phones in the restaurant, let alone people who are strangers to each other, checking up on each other. So that's actually profound. But Dr. Mostafa Shalaby, I'm very interested to know with regards to your journey of how that transition, I guess, in terms of growing up in a certain way, but then realizing that actually it is important to open up and it is important. So how was that journey of like, you must have obviously gone through some experiences in life, some different, experiences which made you realize that.
So I grew up in the Middle East. I mean, so I was in Egypt till I was about 4 years old, and then moved to the UK, and then moved back to Egypt when I was about 10 or 11. And that was probably, looking back at it, was one of the most difficult transitions of my life, because the culture is very different. People are very different. What's expected from you is very different. And then I remember my mom telling me, oh, you're not allowed to do this in Egypt. You're not allowed to do that in Egypt. And as a child, you get really confused. And mental health, I would say the whole of the Middle East really, but especially in Egypt, it's things are really, really behind. And it worries me so much because obviously now that, people trust the system in the UK, which is great. And then, some people would text me and be like, oh, I have a friend who has suicidal thoughts. What do you think I should do?
Yeah.
And then they would say, oh, I'm thinking of taking her to a life coach. And I'm like, what do you mean you take her to a life coach?
Life coach in Egypt?
Yeah.
Okay.
Because one of the issues is, that in Egypt, I don't know about in other areas, but in Egypt, some life coaches, unfortunately, present themselves as psychiatrists, because people don't know the difference between a psychiatrist, a psychologist, a psychotherapist, or a life coach.
Okay.
And it's and I think even in the UK there's a lot of people who don't know the difference between a psychologist, a psychiatrist, and a psychotherapist. And it's like a whole different, they're completely different from each other. We have completely different types of training. Our job is completely different. We do completely different things. So it's quite a big thing that people need to be aware of.
So there's a lot of unawareness, and there's like a lack of education when it comes to mental health in Egypt. Is that what you found? Or
yeah, definitely. Yeah, I think things are improving a little bit now, but then the spectrum is a bit strange, because you get people who don't know anything about mental health at all.
I see, yes.
And then people who think, oh, I need to go to a psychiatrist because I went on a holiday and I wasn't very happy in my holiday for like a week.
Oh, okay.
Or I didn't sleep well for 2 nights, so I need to take sleeping tablets. And then, it's like one extreme to another. While it should be, when you actually need help, you need to go and you need to ask for it, and then that's the help that you'll get.
So you said it's more of a, more ignorance type and lack of education and stuff like that in terms of in the, mental health.
I wouldn't say ignorance, because it's not people's job to know about this.
Yeah. Fair. But it's not the fact that it's like a taboo. It's not like sort of like when people let's say family members say that they might be depressed and stuff, people like sort of tell them or like hide it, or
it's a massive taboo. It's a massive taboo. And something like schizophrenia, for example, you would find people in the street who are probably homeless and, of extreme poverty. And actually, if you go and speak to these people, some of them at least, you'll find that they actually have schizophrenia, which wasn't treated for about 10 years or 12 years or something. And people just ignored them and run away from them. When all they need is probably some medication for a period. And then they might actually have had a completely normal life before it, but they never got the help at all.
So the main thing was for you was the transition period between obviously the West and Egypt, and that's the main thing. You saw the comparisons between the two and adjustment process, which led you down this path. Right?
Yeah, because in a way, I've always wanted to do something where I would feel that I can make a change. And that's when, like, something like surgery, I didn't feel I was very good at it, and I didn't think that I could actually make a change. But my main mission is to kind of, I think still in England, there's a massive stigma, and I think things can improve so much here also. But when you come to the Middle East, that's like a completely different, you know, like anything is really helpful there. Like I gave a presentation, I think it was last summer, talking about postnatal depression in an obstetrics and gynecology conference. And you're talking about their, you know, being professors and, you know, very important people, but a lot of them didn't know much about postnatal depression at all.
Wow.
And when I gave them the statistics, they were like, oh, we didn't know that at all. And I was like, you're a professor, you know, like.
Yeah, there is. I think the difficulty with mental health education is that, you know, like in different areas, like different communities, there's a different problem essentially. So, for example, back home, my country, East Africa, Somalia, Somaliland, etc. There was more of the issue is more of it's a taboo. In a lot of places, like, you know, some people and also there's a, you know, maybe a lack of care, like similar to what you mentioned about the person who has schizophrenia, where everyone sort of didn't really provide them with any help and stuff. That's what we usually get in. So I feel like with mental health, I think the difficulty in approaching it is, like, you know, you have to know the community that you're dealing with, and you have to know the people within that community and what the helps that they need, or the aid and assistance that they need is specific. Essentially, it differs from.
I agree with you
community.
a lot, because, you know, part of a training is we have to go rotate between different hospitals. So I worked in Chelsea, I worked in Brent, different areas, and you see that the problems are completely different. Like in Northwest London, there's a very big drug problem. You know, you've got spice, you've got cut, you've got, you know, many different types of drugs, and you see that, you know, this population has this issue much more than Chelsea, for example. You find that there's other issues going on there. So I agree with you that this is a very important thing.
So I just wanted to ask you that, I found that very interesting when you mentioned that the individual might be homeless, but he hasn't been treated for schizophrenia. So what are the main psychiatric illnesses, like the main ones, which the society should know about and they should have some basic understanding of? So we have maybe schizophrenia, depression, and things like that. What are the main ones
So the main ones, I would say schizophrenia is obviously very important. Depression is very important, especially when it, you know, all of types of depression obviously are important. But, you know, if someone has suicidal thoughts, then people need to be aware of that. Anxiety, very important also. Bipolar affective disorder, very important, because if someone's having a manic phase or a depressive phase, all of that is very important. Autism. Autism is really, really, really important, especially between the medical community, especially doctors, because I've seen it a lot where people would be misdiagnosed as something like schizophrenia when they have autism, because, you know, people with autism, if they're having a very difficult time, they might act out in a different way, and then people might perceive that completely differently and diagnose them with something like schizophrenia. So that's one of the very important things. These are the main things, I would say, because schizophrenia is kind of like an umbrella term. So, like, you know, all types of psychosis, drug-induced psychosis, dementia is obviously very important also. But
And you know, on that note, you mentioned depression. I think the issue with depression in our communities in the West, in the East, wherever country, I think this is a common problem faced by many, is that people struggle to differentiate periods of sadness or feeling sad at a specific time and also being depressed, clinical depression. I think there's a stark difference between the two. Could you, like, you know, what's your what sort of comments or advice could you tell people to help them differentiate between the two?
I love this question. It's a very, very, very important question. So you must have had exams in medical school. Okay, how did you find them? Were you feeling stressed?
Yeah.
Okay, does that mean that you're having mental health? Does that mean that you have to have antidepressants now? No. So all of us go through stress, and that's, you know, it's a very big, again, it's a spectrum. Everything in psychiatry really is a spectrum at the end of the day. So with depression and sadness, it's okay to feel sadness, you know, especially if there's something that has happened. So you might, you know, be grieving for someone close to you who has passed away. You might have had a breakup in your relationship. You might have lost your job.
Yeah.
It's normal to feel sad.
Yeah.
Okay. But it's all about how sad I feel and how long I'm feeling this way.
Okay.
So if I lost my job today, okay, and I spent 1 to 2 weeks staying at home, not really going out that much, feeling quite low in mood, just watching TV, but I'm still looking for jobs. And then after 2 weeks, I call you and I'm like, oh, I just found this job.
Yeah.
And I'm going to apply for it. Fast forward 2 other weeks, I'm in the new job. I'm feeling back to life. I'm feeling normal. I'm going out again.
Yeah.
That's fine.
Okay.
But if the same situation happens, okay, and I kind of isolate myself for about a month, and then you find that, oh, actually, I've been isolating myself for 2 months. You call me, oh, where have you been? And then I'm like, oh, I haven't been sleeping well, haven't been eating well. We used to go to football games together. No, I'm not interested in going to these football games. I don't really want to meet anyone. I've lost a bit of weight. I'm having these unusual thoughts that I never had before.
Yeah.
Then that's when you worry about someone.
Okay.
And then that's when you say, okay, maybe you need some help. Maybe, you know, it's the duration and the number of symptoms in a way.
That's interesting. I think that's very important for the viewers, because a lot of people would say, oh, I'm depressed. It might be like, you know, a fleeting episode of sadness, or a time where, as you mentioned, like it might have been due to stress, like exams. They might not have got the exam results they wanted. They might have got fired from work, and there's a brief, you know, like episodic sadness that you feel, which is normal. Obviously, we're human beings. We're supposed to feel almost nearly every emotion.
Yeah.
But then people sort of conflate that with depression, and you tend to see that a lot. Some people will even say it, like, you know, even the speech, the way people speak, they say, "Oh, I'm depressed."
Yeah.
Where I feel like it's not only is
the word is very it's abused.
It's abused. Not only is it insensitive, also to people that are genuinely like, you know, feeling like that, like people that genuinely feel like that. But also, it's not only is it insensitivity, but also it's not, you know, for yourself, it's not the correct term. You know, we've watered down the term depression and feeling depressed. So I think it's very important what you mentioned.
Yeah, and one of the things that's also, I think, very important related to this topic is antidepressants, because this really, like how people perceive that antidepressants are, you know, the same thing as benzodiazepines, where you're not supposed to take them the whole time and things like that. That's one issue. But also people thinking that antidepressants are addictive. Antidepressants are not addictive. I can say 1,000 times, antidepressants are not addictive. But you need to obviously take them, you know, according to how you're supposed to take them. So you can't stop it suddenly. You're not going to feel a difference in one day. You need to give the medication time, like 1 month, just to start to feel the effects of antidepressants.
Okay.
So to go back to your normal self in a way might take about 3 months or something. And it's a commitment, and you have to be ready for it. And you have to discuss your feelings about it. So if you get side effects from it, don't just ignore it and say, oh, I'm going to throw this medication in the bin. There's a lot of alternatives. Maybe you started on a higher dose than what you're supposed to start on. Maybe you can switch to another medication that will work. There's so many things that can change. Yeah. But all you need to do is just discuss it with your psychiatrist or GP or whatever.
Okay. That's a good point. That's a very good point. I think actually it would be good for you to also give us, like, you know, a few other so obviously antidepressants are one way of managing sort of depression. Yeah. But there are obviously other alternatives as well. Yeah. So I think it's good for the viewers also to know, like, what are the other alternatives one can do if they have a friend who's depressed or clinically in depression or dead in depression. What do they sort of do?
I mean, if we're talking about the NHS, then, you know, it's kind of straightforward. Go to your GP. They refer you according to what you need. But obviously CBT is one thing. But CBT, I would much rather a psychologist explain it than myself, because they're the pros in that. That's their main job. And that's one of the differences, which is very important. You know, like psychiatrists, we're very good at diagnosing, managing, risk assessing, giving medication. That's our main job. But psychologists are more towards therapy and, doing CBT, things like that.
Okay.
They're the specialists in that.
Yeah.
Okay.
But there's many types of, there's a lot of help according to what that person needs, because you've got also PTSD. There might be different types of therapy that they need. You've got personality disorders. They need also different types of therapies. So it's very specific. And that's why I don't like to say like a specific thing that you need to do that. But one of the things that I do feel that everyone should do, everyone, including me, you, all of us, is therapy. Psychodynamic psychotherapy, I think, is something crucial that in the States they're much better than us at that. Like you'll find everyone who could afford it, they'll say, oh, I see my therapist. Or
they're more proactive, yeah.
Proactive mental health, that's basically.
And the stigma is much less there also.
Okay.
So everyone is open about going to see a therapist. And in the UK, there might be a bigger number of people now going, but they're still quite scared to say that I'm going to see a therapist. Yeah.
That's interesting. It's not widely, people don't widely share it. And I think it's very also important for us healthcare workers, especially, we obviously mentioned COVID pandemic. The pandemic was, obviously we mentioned that mental health in the general public was perpetuated, but also there was a lot of stress and underlying mental health illnesses that weren't sort of publicized in amongst healthcare workers.
Yeah.
So so I think it's also a good form, like as I mentioned, like when we speak on the podcast and when we have debrief sessions after work and sometimes, and it helps us, it's therapy for us. And I think this is something that healthcare workers in general, because we work in a high stress environment, especially in hospitals, there's a lot of trauma that you see. So I think it's important for us also to seek therapy, either amongst other healthcare workers, or also actually get a professional therapist and seek.
Definitely. And the BMA provides that. Like the BMA does provide that. I don't think it's completely free, but I think at the beginning it is, and then afterwards you need to pay a certain amount, but they do provide that. Yeah.
It's just very interesting if you think about it as a concept. Like many people, they'll say, I'm going to the hospital for a checkup or for a scan, or they might say, I'm going every morning for my yoga class, for my gym. And obviously we do understand that physical health has carryovers into mental health, but you don't often hear that practice of like, I'm going specifically for a practice just for my mental health primarily. Like maybe I'm going to see a therapist, or maybe I'm going for a retreat, like a mental health retreat or something like that. Or I'm taking a small break from work to optimize my mental health, things like that. It's actually very interesting that you said that, and I think it should be more commonplace. But like, people who are living with someone who's depressed, right? They might be surprised. They see like the tendencies which they're displaying. Like, for example, maybe the individual is struggling with motivation, struggling to do general activities. But as someone who's caring for that, what are the things which they need to understand about the condition of depression in order to provide that care in an optimal, supportive and loving, restorative way for them to improve?
I mean, they need to, with someone with depression, they need to know that it does take time for people to get better. Like, unfortunately, it's not like surgery where someone will go have a surgery and then the next day they'll be better.
Yeah.
It's quite a long process at times, especially when you talk about antidepressants. It does take some time. But at the end of the day, the important thing is that the first thing, and one of the most important things, is that they need to look after their own mental health.
Okay.
And that's why we normally do a carer's assessment to actually see how is this person coping with looking after someone who's got schizophrenia or depression or bipolar or whatever, because sometimes they can neglect themselves so much looking after someone, and then they themselves end up with a mental health issue also.
Wow.
So they need to really look after themselves. And luckily in the NHS, there's these programs, carers support groups, things like that. There is support for people. They need to understand about the mental health issue that their partner or the person they're looking after has. So they know that, someone with depression might not really have much motivation, might not be having the energy to do certain things, and educate themselves about the medication that this person is taking. Just really follow up with them and make sure that they're getting the right support. But also the red flags, they need to be aware of that. So, if if their partner is telling them, oh, I'm starting to have these suicidal thoughts, then that's a massive red flag. Then they might need to take them, like I said before, to A&E or call 111. So they need to know about these red flags if, to support someone.
Okay. That's interesting, like this carer support program.
Yeah.
So do psychiatrists, as doctors, as professional psychiatrists, and other medical doctors, surgeons, we also deal with a lot of trauma. And, as I mentioned, so there is obviously BMA, we mentioned, offer therapy sessions for that is available. And generally the NHS does support. They do have various supports systems in place. But what have you seen? What's your experience in terms of is this something that psychiatrists generally, because obviously they're dealing with suicidal patients, depressed patients, that can have a lot of a big effect on themselves, their mental state. So do you tend to see them seeking help more often, or?
So there are two separate questions. So the first question about, do psychiatrists seek more mental health than other doctors? I would say, so for me personally, I think that because a lot of people ask me that, they say, oh, is it very stressful because you're working in mental health, seeing all of these patients with mental health issues, being depressed, being suicidal, does that affect you? I think of it as a positive way. So for me, I get people at their lowest point, which is obviously a very sad thing. But then I the way I normalize it in my head, or the way that I don't get too much affected by it, is that, this person is going through that. Luckily, my life is going okay. So I feel more grateful for my life.
Oh, I see.
Wow.
Okay. But at the same time, also, I have much more, no, I wouldn't say much more, but I have more insight towards mental health. So I know more about my mental health. So I know if actually, I need to do this, or I need to do that, or maybe it's time for me to have therapy. Maybe I need to do this. So that makes me have more insight. And I think that's a very great thing, because, I get to see, maybe I haven't been, I took a month and a half off work recently between two jobs. And I was like, okay, I was very stressed from registrar training. I was like, this was too much. And I'm going into a completely new job. Okay, I asked my new job, can I take an extra month off? And they said, that's fine. I used 2 weeks of annual leave from my previous job, and I traveled for a month and a half.
Brilliant.
So that's what I normally do.
I
can't remember what was the first question.
So it was a two-part question, but I sort of I mixed it in.
I remember now the first question. So your first question was towards how do psychiatrists, or can they help kind of like the general doctors, or the medical doctors or surgeons? Yeah. So I think for me that's a very important part, and that's why I chose actually the current specialty that I work in now, which is liaison psychiatry. So in liaison, you work in a general physical hospital, and you basically see patients in A&E who come via the GP or present themselves, or through the police on a section 136.
Okay.
And you also see patients on the ward. So if someone's having surgery and maybe they're having suicidal thoughts, we would see them. Maybe they're on drugs or something, and we need to just check their medication, things like that. So that's a very big part of it. But also a lot of the times it is to kind of look after the medical team also.
Okay.
And I think that's the best part of it, because first of all, the medical plus surgical teams, they actually see what we do, and they see that actually we do make a difference, because they can get an extremely chaotic patient on the ward and they're unable to look after that patient. But we're able to kind of take control of the situation, help the patient calm down, give them the right medication. So that's a very important part, but also sometimes they themselves get really stressed dealing with a very difficult patient maybe. So then we're able to kind of ease their stress also. And that helps a lot. And that's what I'm planning to do, is to do more teaching for medical and surgical trainees on how to deal with stress, how to deal with, difficult patients, but also communication skills. Because I think that's a very important part. And I think it's one of the, you guys learn it a lot also, but I think in psychiatry, it's that extra bit, because you see someone who's incredibly unwell, and your main job is to get information out of them and to kind of calm them down.
Yeah. I saw that. I did a psych placement in third year. Was it third year when I was a medical student?
Okay.
And I saw how important communication was. We tend to rely on in medicine generally, like there's other things you rely on: investigations, bloods, clinical examination, especially surgery. Like your bread and butter is examining the abdomen. So,
Yeah.
but in psychiatry, your main form of sort of gaining information is obviously you communicating with the patient. Even the way the patient communicates, was their speech too fast, was it too slow, etc. I had a question I wanted to ask previously, because obviously the COVID pandemic definitely affected that. Obviously, like it affected other specialties in different ways, but in psychiatry, you're not face to face with the patient anymore. There wasn't it wasn't widespread face to face consultations. Some might have been on video, I understand. So how did it affect your sort of consultations when it was sort of maybe over over video rather than it being a face to face consultation?
Yeah, I mean, I think they did it in one of the trusts. So I don't know if you know about mental health act assessments. So mental health act assessments is when someone's, came through a 136.
Oh, yeah.
So someone who's in the street or in maybe even at home, and they're brought by the police or by an AMP, and then you do a mental health act assessment where you decide actually does that patient need to go into hospital or not, or can he go home willingly, all of these things. And I think it was tested in, I can't remember where, but I think in maybe south of England, where they did these assessments through video, and then it was completely stopped. I don't really agree with it at all, especially in psychiatry. If you say in therapy, I say it's fine. Maybe with the community, as a psychiatrist in the community team, again, it's not really a preference at all, but in every other situation, I think it has to be face to face in psychiatry. It has to be, because like you said, we don't, bloods, all of these things, all of these investigations are important, but for us, we don't really. It's all about what I'm seeing from that person and how to make them feel at ease and how to get the information from them, and that's incredibly difficult doing that through video. It has to be face to face.
Just wanted to touch upon something we spoke about earlier, and it's that every single specialty in medicine, they face their own forms of stress, and it's a different form. So for example, we had an orthopedic surgeon on recently, and we were discussing the stress which one faces in an adult trauma call,
of course, I've been there. I've done it. I didn't enjoy it at all.
We're doing that like secondary surveys and primary surveys like 10 times per night. Obviously that's going to stress you in a different way. I'm currently in geriatrics placement, so I'm dealing with a lot of end of life placements, end of life situations, and I'm doing a lot of family discussions for end of life, and
which is also extremely difficult.
It can be very difficult. Like I remember once at lunchtime as well, I was just on the phone and I basically found out some devastating news, with regards to my personal life, regards to family, things like that which occurred. And, I was close to shedding tears at lunchtime because of what was going on and with regards to that. But then I just had to wipe it away and just go. And I was dealing with a family discussion for a patient that's end of life. And what was in my mind, but I just had to put it to the side, cancel it for that moment, because now there's someone else who needs my help, needs my support. And I was just there and then later on after the shift, I was just thinking through, just discussing with my family, how I actually felt about this whole situation. That in and of itself is a form of therapy. But for the psychiatrist, what actually is it? Like, what kind of traumas do they experience? That you mentioned that you put like a positive twist to it with regards to how it's grateful, but like what kind of traumas can they face as well?
You mean psychiatrist?
As a psychiatrist, like just dealing with seeing all these patients in different situations.
So much you can deal with, so much. Trust me. I mean, one of the things is you can get very aggressive patients, and I remember like one of my night shifts when probably like my second year of being an SHO, we had literally 2 or 3 special forces police come over. About 12 special forces police bringing one person. And then I don't know if you're familiar with a seclusion room.
No.
It's like in the movies where, like the padded cells, but it's not really padded in, well, at least in the hospitals that I worked in, but it's basically when a patient's really unwell and they're very aggressive, until they calm down, we would put them in this room. And then I was asked to go and see this patient. And at that time, the police had left, and it was like me and a few nurses go and see this patient. And I was terrified. honestly, I was literally terrified. You know, I was like, it took 12 policemen, special forces to bring a patient. Now you're asking me to go and see this patient at like 2 a.m. So aggressive patients is very difficult. Sometimes the communication could be quite difficult with some patients. So sometimes they can tell you something, you know, they can make fun of how you look or your name, or your, you know, be like, oh, you know, I'm Muslim, so they can be like, oh, you know, you're a terrorist or some things like that. So that also could be difficult. This again, I rationalize with, you know, like, this patient's really unwell at the moment. I can't really take for granted what they're saying. They probably don't mean it. And a lot of the times when they get better, they would apologize for what they said. But the most difficult and stressful thing is having a patient that you know end their life. I don't think there's anything within psychiatry which is as difficult as this. And when I've experienced it, it was probably the hardest period of my life even. Because you get this sense of guilt. What if I had done this? What if I had done that? Maybe I could have done this. Maybe I could have, you know, I went by the book, you know, the book says that I'm supposed to do this. That's what I followed, but still this patient ended their life. Is it my fault? Is it the book's fault? You start to, you know, disbelief in what you do or how you do it or the system, everything. It's a very, very difficult thing to go through.
Like, that's a different level of trauma. I don't think, like, you know, I think that's something that one has to, you have to be in it to experience that, and, like, you know, to understand or empathize with how, like, you know, psychiatrists deal with that. And
it's actually very interesting because I was traveling and I was in Colombia, and I remember, like, I was chatting with a friend, and then I told her that, you know, I've been through that and it was the most difficult period of my life. And obviously at that time she was like, oh, you know, like, I'm sorry to hear about this. And then we just met a week ago after I came back from my travels, and she had a friend pass away through suicide. And she was like, I just remembered you, and you know, like, this is how I feel right now, and it's like the most difficult feeling I've ever had, and I blame myself. You know, and it's a friend, not your patient.
Yeah.
You know, so yeah, it's a very, and I mean, I guess, you know, in surgery and medicine, the feeling is probably the same if you have a patient pass away and all of this. But suicide, I think, is the most.
What you know, we did we briefly spoke about, like, you know, things that the viewers can do, like if they have a friend who sort of they might feel is suicidal or might need help. But, you know, like, we have obviously we've all done medicine, we know about basic life support, and a lot of the public is promoted and is pushed, you know, like, what basic life support is, how to administer it, young and old, everyone seems to know, most people know anyway. Is there something, like, similar to that, but, like, from a mental health point of view, in terms of, for example, suicide? Obviously that would be, you know, if we were to do a comparison, illnesses of the body and illnesses of the mind, suicide would be sort of, you know, like, the, you know, on the spectrum will be sort of the highest. Is there anything, like, you know, we can sort of the public can take away, the viewers can take away, that, you know, like a 5-step point or something that they could sort of remember to do in a situation, for example, in a patient or someone that they know might be suicidal?
I mean, it's very tricky to. So there's, my understanding is, and I might be wrong, I know that there's, you know, a lot of people are getting mental health training now, especially in companies and things like that, which is a very, very important thing. And I hope to, you know, be able to promote that one day. I would always say never take the risk, really. You know, if I'm feeling someone's acting in a very different way from how they were before, you've got the NHS. It's an incredible system, honestly. And I'm not saying this because I work in the NHS. There's a lot of problems within the NHS, but I think in terms of mental health, it's a very good system. Honestly, like, even when you compare it to private, because we get a lot of private patients, you know, who have seen private psychiatrists, and you see the difference, because the NHS, you've got the community team, you've got the home treatment team, you've got the hospitals. It's a very, you know, all the system is combined together. So there's a proper system. While if someone sees a private psychiatrist, for example, there'll be an issue with the inpatient, or, you know, there's not that system, or there's no home treatment team, things like that. But I would say don't take a risk. Always, if there's any doubt, either call 111 or go to A&E. That's the only thing you can do. But don't, you know, there's nothing that this person can do to kind of stop this, but they have to kind of get the right support.
I think that summarizes it well, to be honest with you. I think that's a very good takeaway for our viewers as well. I think, like, you know, especially the point you mentioned about not taking risks. It's always, don't try and sort of be like a hero, or if you, like, you know, don't brush it under the carpet. Again, there's a lot of, like, sometimes we're unaware, or we might take it lightly because obviously we're not the importance of mental health is not sort of promoted within society. But it's very important to, like, you know, if you feel a friend or you feel yourself, you know, or a family member, a loved one, or whoever they may be, you notice that someone might have these suicidal thoughts, might be thinking about taking their own life, to try and do, like, you know, just refer them, try and get them help as soon as possible.
Yeah, always get professional help. Don't kind of take on yourself.
Yeah.
You know, if I have abdominal pain, I'll go to A&E. You know, I'm not a surgeon. I'm not expecting, you know, to do anything. I have to go to the right place straight away. Don't take risks, basically. Yeah.
And to be honest, sometimes we just need to ask.
Yeah.
It's actually profound. Like the phrase, how are you? I think that needs to be expanded upon, and actually someone sit down and say, look, how are you? Is everything okay? How have you been? It's not just you're passing someone in the hallway and you say, you're all right.
Yeah,
you just
you're
nod
right,
at each
mate.
other. Yeah, you're right, mate. And then the other person doesn't even reply. How is it? He just says, "You're all right." And it's not even a conversation. Like, just sit down with someone, and they pretty much 10 times out of 10 they'll open up with you. If you spend time with anyone, everyone just opens up because everyone's going through something in life. And
You reminded me of a very interesting story. I don't know if you've heard of this Facebook group called Tea and Empathy.
no.
So I was in a conference in 2016, I think. It was my first year as a core trainee. And this lovely, I think she was a psychiatrist, and she herself had mental health issues, and she spoke about them in a lecture, which was one of the best things I've ever attended. And she said that as an F1 or F2, she was doing ward rounds, and she had like a family situation similar to what you were saying. She had like a very difficult family situation. And then she, I think, had to, like, work was extremely stressful during that time. And she said that for the last like 3 weeks, she was feeling really mentally drained and really unwell. And one of the cardiologist registrars she was referring a patient to, left her a note with his number and said, I can see that you're not doing very well. Would you like to have a cup of tea? And then she went and she spoke to him, and then she, you know, he asked her to get some help, and she got some help, and then she was able to actually complete her training and do all of this. And then that's when she set up this group called Tea and Empathy, where people say if they're struggling, especially doctors. And then now in some hospitals, they actually have this where, you know, if you're on call and you're stressed, there's a number to call, and then someone would come and have a cup of tea with you.
Okay.
You know, which
That's
is
a very good
incredible.
initiative.
Yeah.
Yeah.
It's definitely worth it. Yeah.
Definitely, yeah, that's very important. That's very important. We're just going to wrap up now, obviously conscious of the time, but just a few more questions. Just wanted to discuss with regards to the stereotypes for every different field of medicine and surgery. The conventional society might think, okay, trauma and orthopedics, maybe.
Tell me about the psychiatry ones.
Yeah.
I'm excited to
What do
hear
you think
them.
about the psychiatry? Like, what kind of skills does someone need in order to be like a good psychiatry?
Okay, that's a very good question.
Yeah.
To be a good psychiatrist, you have to love it.
Yeah.
Okay.
If you don't like it, it's going to be the most boring job in the world. And it's very easy to, you know, I watch trainees a lot, and it's very easy to see a trainee one time and say, you know, they definitely don't like this job at all. It's very, very easy to spot, because you're spending about an hour to an hour and a half talking to someone. If you're not genuinely interested in people, that's not the right job for you. So it's all about communication skills, because it's very easy to read a book, get the medication, but to get a patient who's extremely stressed, extremely unwell, to be able to have a conversation with you for an hour, that's a skill. And you have to love it. Yeah. And if you love it, it's the best job in the world. Honestly. Yeah.
100%. First of all, I just wanted to actually tell you a story. I was basically in one MMA class.
Okay.
And this was near the campus, where a hospital, right? It was a time where I was living on the campus on hospital.
Yeah.
I saw another individual there who I recognized from the hospital situation as well. And I was just discussing with him, you know, his journey in combat sports and training and stuff like that. I was like, what made you get into this? And he was like, look bro, I'm a short guy and I don't want to get bullied in psychiatry. I'm just doing this so I can be safe. Have my psychiatry rotation right now, and I'm really struggling with that. I don't feel safe when I'm going to
He doesn't want to be overpowered by what the individuals there.
yeah, the patients. He was genuinely scared, so he ended up in the MMA class because of that.
He wanted to become a force, like, you know, the SWAT team.
Yeah. I mean, again, so this is like one of the things is that, you know, I can't remember exactly, but I remember reading that, you know, is in like, you shouldn't be scared of a mental health patient. You know, there's this thought that any patient or most of patients with mental health issues will be physically aggressive. Then that's not true at all.
Okay.
And it, you know, it's one of the things that people need to be more aware of is that, you know, it's most of the time that doesn't happen. And if someone does get physically violent for any reason, it's a lot of the times, you know, they're having delusions about the people, they're not feeling safe, they're hearing voices, and always try to put yourself in their place. You know, like if I'm hearing a voice that you're trying to harm me right now, of course I'll be very worried about you, and I might even, you know, but that's why we're there to help them and to risk assess and all of this again.
Most of the time, as long as you said, you're good at communication, you can sort it out. Communication is your biggest weapon in psychiatry.
It's the best.
Like I'd say even like obviously you're in the field, so you can give us a more accurate distribution. But I'd say it's like 95% communication, 5% medication in terms of like in terms of when you're dealing with an aggressive patient, majority would be communication. Then you can resort to like, you know, sedatives and stuff.
Yeah,
like that.
I mean, it depends on the situation, of course. Sometimes it's even unsafe to enter the room, and sometimes we do rely on medication, which we don't try to. But again, even when you're talking about medication, you have to put communication skills in it, because if you're giving a medication to a patient, you haven't clearly explained to them, especially if they're paranoid, you know, got paranoid schizophrenia or something, and you just tell them, oh, you have to take this medication. They might be too worried to take it, and then they might pretend to take in front of you and spit it out or something. You know, if you're giving someone antidepressants and they don't really believe that they should take it, they'll probably throw it away. If you don't explain to them the side effects, you know, if you don't explain to them how to take it. So it's all, the majority of it is communication skills.
Thank you so much for those amazing benefits. We just wanted to kind of share with you the opportunity. Obviously, we have a platform now. We have people watching us. And kind of like a public service announcement for anyone to, you know, just any advice about mental health, which you think is most pertinent at this time. You know, the importance of mental health, taking it seriously, reaching out for help. So just wanted to open up the floor for you just for a final message.
One of the most important things, I believe, and going back to talk about men's mental health, obviously this is also for women, is that a lot of people ignore issues, and they say, you know, like, oh, I had this trauma when I was young, but, you know, I don't really care about it. I don't think about it, and it's completely fine now. The thing is, if you don't address these issues, okay, they'll get much worse with time. And you don't have to see it on a conscious level. But the more you bottle up these things and the more you don't address these issues, the more, you know, they happen and they're making a change and they are impacting you, but you're not consciously aware of that. So try to address your issues as much as you can, and don't let them bottle up, and address these traumas that you've been through. Therapy isn't going to, you know, the thing about therapy is that therapy is not going to completely, you know, delete all of these traumas, but it's going to let you understand what happened and how to accept these things and how to move on from that. And that's what we all need at the end of the day.
100%. And just to tie this all together back to the start of our conversation, obviously, you mentioned that you grew up in Egypt and you're from Egypt, and there's a different perception of mental health there. So I just wanted to ask you, I think it's just befitting for us to end in Arabic as well.
أكيد.
هل لديكم رسالة لأصحاب الأمراض النفسية في مصر وفي العالم العربي؟
ليا رسائل كتير، بس أهم رسالة أولا للدكاترة النفسيين، إن هم قدامهم مهمة كبيرة قوي، وإن هم فعلا يراعوا ربنا في العيانين، لأن للأسف لحد دلوقتي بيحصل أخطاء كتير من الدكاترة النفسية، وعشان كده في lack of awareness شوية، لأن الناس متلخبطة نفسها. وتاني حاجة إن لازم يبتدي يبقى موضوع الستيجما يقل جدا في البلاد العربية، لأن لحد النهاردة لو حد قال لحد إن هو بيروح لطبيب نفسي، دي مشكلة كبيرة قوي، والناس بتخاف منه.
صحيح.
فلازم موضوع الطب النفسي ده يكون زي الجراحة زي البطنة زي كل ده، واحنا متأخرين قوي في الموضوع ده.
سبحان الله. والأمراض النفسية مش عيب
خالص.
كما قلتم في
ما فيهاش أي
الانستغرام.
حاجة. مش عيب، لا. كلنا مرضى نفسيين.
That's absolutely profound. Everyone has mental health issues.
Yeah. And obviously for the viewers, we'll add the subtitles, we translate. Thank you very much, Dr. Shalaby. It's an honor to host you.
Thank you so much.
I think it's also extremely important. I think me and Inam ourselves on StriveMed, we're trying to do our part when it comes to mental health, and also trying to ensure that, because obviously we're all from diverse backgrounds, we're all from various ethnic backgrounds. So as I mentioned before, each of our communities see it in a different light. And it's important, we tackle it head on, and we also raise awareness and education. And I think how you've come onto the pod, you've, sort of like, you've demystified and you've sort of tackled a lot of the issues that our communities face. So we would also love to have you on again.
Thank you so much. Well, I want to say two things. First of all, like, I've literally just met you before this and we haven't even had, like a chat. But you're very, very easy to talk to, and you make I'm one of the people who actually gets really nervous in situations like this, but you've made it so easy for me. So thank you so much for doing that.
Thank you.
And what you're doing is great. I mean, I didn't have any time at my F2 job. I don't know how both of you are able to cope with doing this also. And it's very meaningful and it's very important. So no, thank you for bringing me here. And thank you so much for what you're doing on a weekly basis. It's amazing.
Thank you very much.
I appreciate that. Thank you so much. How can the audience find you?
Dr.Mostafa Shalaby on Instagram.
On Instagram, yeah. Thank you so much.
Follow
us on Instagram, StriveMed, TikTok, StriveMed, www.strivemed.co.uk for more support. And that's a wrap. We'll see you next time.
Thank you.
Take care.